For our table of contents today, I'm going to start out with a little bit of background about spinal cord stimulation and just neurostimulation in general. We'll talk about the covered diagnoses, which will be very important for your futures. I'm going to go over something called the SAFE principles. We're going to talk about the primary indication for stimulation in the United States right now, which is failed back surgical syndrome, and go through the literature. We'll talk a little bit about the vendors, the societies, the journals. How do you make a decision as far as what to do, especially now in 2016? And then what are the outcomes we look for? And then Lawrence is going to talk for about an hour and a half, and then we're going to come back and do some case studies around 10 o'clock. So if you were talking to your grandmother about what neurostimulation is, one could simply say it's providing electrical currents to an electrode that resonates at a specific frequency on the spinal columns to mask pain. Now, that would be a pretty sophisticated grandmother to understand that, but it's a start, okay? How does Tylenol work? Anyone know? I don't either. Neurostimulation, there are a lot of theories as to why it works and how it works, but we truly don't have an understanding of exactly how it works, okay? So especially as we're learning about new technologies, new waveforms, and new things about what electrical stimulation does to neurons, we still, as of 2016, don't have the clearest idea of exactly how it works, okay? So if we go through, remember our anatomy from med school, we remember our nerves, the fibers, the classifications. Which fibers are we most interested in as pain managers? A delta and C fibers, excellent. So as you know, both A delta and C are for nociception, and then of course there are differences between these two. And in 1965, Melzick and Wall came up with something called the gate control theory. And the idea is if you stimulated the input from A beta, which as you remember was pressure and light touch, it would turn on an inhibitory interneuron in the substantia gelatinosa that would then put negative feedback on both the A beta and C fibers. It's pretty amazing to think about that only 2 years later, a neurosurgeon decided to take this theory and apply it to clinical practice. And this was Norm Shealy in Wisconsin in 1967. And what he did in a palliative care situation, a patient who had pretty advanced cancer, was put in leads into the intrathecal space, okay? So this is very different than what we're doing these days as far as putting leads in the epidural space. We're actually putting them, Norm Shealy put them right on to the spinal cord. And he actually sutured it to the dura. And the response from the patient, at least for the first 48 hours while they were living, was very positive. The patient unfortunately passed away 48 hours after implantation due to infectious complications. But this was a very interesting point in history. So we have someone who's applying the gate control theory, 2 years later applying it. It really started to make people think, what could we do with electrical stimulation on the spinal cord? And Norm Shealy at that time, as a neurosurgeon, tried to get this paper published in many neurosurgical journals, but couldn't do so. So he actually was able to publish it in an anesthesia journal, ANA. Where have we gone since then? In 1971 in Japan, Shimogi started using electrodes in the epidural space just to avoid some of the complications, as you might imagine, in suturing around the cord. In 1978, the number of electrodes started to increase, so we had the quattrodes. And before 1981, they were using basically radio frequency to externally power those leads. They were not using an implantable pulse generator like we use now. So not until 1981 did we start using IPGs. 86, you can see the electrodes start to increase. Then we have multi-lead IPGs in 1988, rechargeable batteries. In 2007, we have our first MRI conditional system. And then in 2011, more electrodes. We have positional sensing. And then in the last couple years, high frequency, different patterns. This year in the United States, DRG stimulation. We have bursts now available. And in the future, there's going to be lots of stuff, but I think the hot topic right now are feedback systems. So systems that actually report back as far as position and what nociception and what inputs are being put in to adjust the stimulation over time. So that's a brief overview of the evolution of neurostimulation, and we're going to go into some more stuff as we go along. Now, the problem with the gate control theory is that it unfortunately doesn't explain everything when it comes to neurostimulation. there is a persistence of relief when A beta stimulation is turned off. So if you have someone with a spinal cord stimulator turned off, they'll have hours, if not days, of relief. And that doesn't make sense if you think about the specifics of the gate control theory. And then, of course, subthreshold stimulation does produce relief. You see that with high-frequency stimulation these days. You see it with DRG stimulation as well. So there are other theories. So what else could be going on? So perhaps we're activating descending inhibitory pathways, such as the fasciculus interfascicularis, or the septomarginal fasciculus, dorsolateral fasciculus, or the corticospinal tract. There might be the neurochemical or cytokine changes that we often hear about as far as GABA, substance P, serotonin, glycine, adenosine, et cetera, and a reduction in glutamate and aspartate. Whether these are the causes of the effect or just a result of the effect remain to be seen. But again, these are some of the theories as to how spinal cord stimulation works. You're going to have a lot of things to think about as far as what you're going to use if you decide to do neurostimulation. So here's some of the parameters you can think about. You have anodes and cathodes. You have leads that are cylindrical, and these are the percutaneous leads. Many anesthesiologists, PM&R physicians, interventional radiologists might use. And then you have paddle leads, which involve a mini laminectomy. Usually are implanted by neurosurgeons or orthopedic surgeons, but I'm not being absolute about that. There are anesthesiologists who do it, et cetera. And there are neurosurgeons who do percutaneous leads as well. The frequencies, historically traditional spinal cord stimulation was in a range of 2 to 1200 hertz. But as you probably are all familiar with now, we have high frequency, which can really be anywhere from 1,000 to 50,000 hertz, even though with one system they tout the 10 kilohertz as the frequency. But there are many other frequencies to consider. Pulse widths can obviously vary, amplitudes can vary. And then in the last few years, we started talking about patterns. So I'll talk a little bit about tonic and burst in just a little bit. And then it's very important to understand the anatomy of what you're doing and then the conductivity of substance. In addition, as I write in the bottom, certain systems will be voltage versus current-based or controlled. So conductivity of intraspinal elements, this is from an article in 2002 by Oakley and Prager. The biggest dissipator of your electrical current is through the CSF. And that is something you're going to have to go through as long as you have epidural leads and you have a dorsal column stimulator. What's interesting with DRG stimulation, that CSF depth is much, much smaller, and so the dissipation of electrical current may not be as necessary or isn't as great, and therefore we are noticing, or we have noticed, that you need much lower currents, much lower power in order to stimulate the DRG than you would for the traditional dorsal columns. Leads will move, and things will change. Insulation can be marred. So understanding those differences in conductivity are very important for making your therapy work. All right, the hot topic these days are really about waveforms. Just to give you an overview, tonic versus burst. So tonic is literally just tapping how many cycles per second, what is the hertz. Historically, it's been anywhere 40 hertz or 50 hertz. Burst is if you take a packet of burst stimulation. So like if I had my 5 fingers tapping on the wood at a certain frequency. So within this algorithm, there are 5 simulations at a high frequency of 500 hertz, and then that happens at a frequency of 40 hertz. And this all came from the research from De Ridder out of the Netherlands, in which he looked at how neurons fire in the central nervous system, specifically in the thalamus. And there are neurons that fire regularly with tonic waveforms, and then there are others that have this burst firing. So the idea was, can we counteract or manipulate the way those neurons behave by changing the way our stimulation works? And so burst stimulation has been around in other countries now for a few years. We were at a meeting in Japan, and everybody at the table from Asia was like, oh yeah, we've been using burst. We didn't get burst here in the US until basically last week or a week and a half ago. So this is something we're going to learn about as we go on through in our experience, and we'll talk a little bit about what we know about it as we move forward. Anyone heard of the SAFE principles before besides Lawrence and everyone at UCSF? Okay, great. So SAFE is an acronym for safety, appropriateness, fiscal neutrality, and efficacy. Lawrence, who's in the back of the room, was part of this, writing this paper and this idea. And it's actually applicable to any new medical technology. Because here we're dealing with a very expensive technology that has an impact on not only our patients, but our insurers and our government payer systems. We need to make sure it's done safely, that it's appropriate, that it doesn't, break the bank, and that it's effective. So you can actually apply this to many things in what you do. It's always important to try to, whenever you're seeing a patient or whenever you're thinking about on a population level what is right, always come back to this. I find myself doing this quite a bit. It can be very useful. Let's start out with safety. A paper from 2007 from Kumar in neuromodulation. So Kumar, he unfortunately passed away just a little while ago. Basically was one of the major neuromodulators in Canada, a nationalized health system, in which they had all of this data regarding outcomes. And so even though the paper came out in 2007, he's looking at data going back several years. And as you can see, the top complication is lead migration. So that's when the leads will move up and down, or up or down or out. 13.2%. Lead breakage, almost 10%. Device malfunction, almost 3%. So those are sort of the hardware issues in the blue. In the pink are sort of the clinical issues as far as infection, hematoma, CSF leak. Those are more rare, but certainly something to consider. And then the programming, or perhaps even related to the IPG itself, are in the yellow. Those are more rare as far as the IPG having pain or eroding through skin. And then undesired stimulation is certainly an issue. And I think as we're getting to subthreshold patterns and frequencies, we're seeing less of that. And people have their own preferences. Not everyone is set for tonic. Not everyone is set for burst. Not everyone is set for whatever waveform comes in the future. I think it's going to have to be a little bit of trial and error, or in the future figuring out who is best for what. But if you add up all these complications, you're going to tell your patients 1 out of 3 of you is going to have a complication. Do you think that's acceptable? No, it's not okay. You can drink, you guys can talk, it's okay. Have more coffee. I know it's early, you guys were probably out last night. But this is totally unacceptable. And true, I'm sure Lawrence is in the back of the room. He's like, those rates are way higher than what we're seeing today. And that's true. There have been plenty of articles in neuromodulation which have shown that lead migration rates at certain institutions are as low as 1% or 0.3%. And that's great, and that's good for them, and that's what we need to see. But I think it's very important for you guys, especially as you're early in your training, to understand where we were just 10 years ago and how I don't want to say we were bad, but I would just want you to know that we have a long way to go to improve how we do this technology and implantation. All right, so what diagnoses are covered? So now we're going to the A, the appropriateness. Really, you can really divide this into neuropathic versus ischemic conditions. So yes, you can memorize a list of 30 things, via Noridian or whatever insurance company or group will cover. But just think about neuropathic pain conditions such as failed back surgery syndrome, CRPS, radiculopathy, peripheral nerve stimulation, occipital neuralgia, phantom limb, stump pain, or residual limb pain, diabetic peripheral neuropathy for some insurers, postherpetic neuralgia, maybe, chemo-induced peripheral neuropathy, certainly now with DRG, and then ischemic conditions, which you don't probably talk about too much in your own institutions here in the United States, but in Europe, spinal cord stimulation is used for vascular conditions such as angina, peripheral vascular disease, and Raynaud's disease, and then, of course, other rare and debilitating chronic pain conditions. So to summarize, you can just think about it as neuropathic and ischemic. The fiscal neutrality, the F of SAFE. So how cost effective is this therapy when some of these systems can cost $70,000? Of course, there's huge variability in the cost depending on your payer and where you are practicing, et cetera. So Kumar, going back to him, who's done a lot of the research regarding this technology, and of course, in Canada, they're very concerned about the cost because it's a nationalized healthcare system. And he looked at the mean 5-year costs between spinal cord stimulation versus conservative treatment, which involves everything you would do normally besides the implantation, imaging, medications, doctor's visits, ED visits, et cetera. And then noted that after 2.5 years, conventional medication management or medical management started to exceed the cost of spinal cord stimulation. And he also noted that 88% of spinal cord stimulator patients were satisfied with their therapy. And then in Deere in 2014, he kind of used some of the Kumar data, but again, looking at the costs over time, once you have an implant that's generally successful, it's going to pay off over the long run. As long as you can have that system work for at least, I would say, 3 years, it's going to outdo conventional medication management. What I do often talk to patients about is, how frequently are you going to the ED? How frequently are you getting injections? What medications are you on? How much does that cost? And if you start to add that all up and give the insurer some idea of what their annual costs are just with the status quo, they will start to realize that, sure, that $30,000 or $50,000 upfront cost may be significant, but it may pay off as long as we can reduce those meds, reduce those ED visits, or reduce hospitalizations. All right, any questions so far? Yes. It can be used. I've done it. Right. And the biggest hurdle is just talking to insurance companies about its use. And I will use the European Society's cardiology guidelines for certain conditions. We've done a case for angina. We've done a case for ischemic limb. And it's worked. So you can do it. It's just not as widely accepted in the United States. And in fact, when I raised this to cardiothoracic surgeons and vascular surgeons at UCSF, they were like, what? Never heard of that before. But Europeans, it's part of their algorithms. You can look up the angina algorithm for management, and if they're refractory to your commonly used medications, you'll see spinal cord stimulation as the option. So, any other questions? Lawrence. They just don't look at that? Yeah. Excellent. Excellent. And have you done any angina cases? All right. Any other questions? All right. Well, let's talk about FBSS. I personally hate this term, even though it's an ICD term. So to have the word failed in it really, says a lot, but it's totally wrong. Pain after surgery is not necessarily a failure. As we know, pain is a sensory and emotional experience. It's associated with actual or potential tissue damage or described in terms of such damage. So what it's getting at is, historically, if you have someone who has a back surgery and then they go on to have chronic pain afterwards, we just give them this trash can diagnosis of FBSS. But there are many things that could be going on. It's not really fair to the surgeon, not really fair to the patient, not really fair to anybody just to give this trash can diagnosis because there's so many things that could be going on. So firstly, it could be due to epidural scarring, fibrosis. It could be due to different stresses now that we've done the surgery. It could be due to arthritis in general, spasm, recurrent disc prolapse, paraspinal muscle atrophy, arachnoiditis, which can certainly be an issue. And then just general neuropathic pain when you just can't figure out why something is happening, but someone is saying, I have pain in this distribution along these nerves. So FBSS does encompass all of this, or post-laminectomy syndrome. It encompasses all of this. So it's actually very important, even though for your future practice where you're going to be using FBSS as your ICD-10 code or whatever else, if you can start to figure out which of these particular sub-issues are the issue, it'll help your technology work better. Because if you do know it's from arachnoiditis, I think it'd be pretty challenging to get your spinal cord stimulation system to work at this time. Whereas if it's due to arthritis or discogenic pain, you might feel far better in the technologies we have. So really parsing that out will be very important. A brief review of the literature. I'm not going to spend much time on this because you're going to have this throughout your fellowship years, and NANS is in January. You're going to go through all of this. But if I were to give an evolution in 1994, North basically said, hey, here's SCS. It can work for people after failed back surgical syndrome. In 1997, we had a review and saying that this is valuable. This is something we should think about. 2005, even a larger systematic review basically said, hey, this is even better than conventional medication management. And then the process trial in 2014 from Deere 47% achieved an outcome of greater than 50% relief compared to 7% in the conventional medication management. And then our latest evidence to support this therapy, which involved a randomized controlled trial, which is actually a huge first for this technology because, again, it's very expensive. These trials are very costly. They're time-consuming. It was a multi-center study, and you probably are all familiar with the anesthesiology study in 2015, which looked at the Nevro high-frequency 10 kilohertz therapy versus an older system from Boston Scientific and compared the two systems. In the next several years, decades, you're going to see more and more head-to-head trials as long as the industry vendors are willing to allow the other one to trial against each other. That's always a hot political topic, but nonetheless, this is a huge thing for us because we need this kind of information in order to know what technology is better than the other. Just taking systematic reviews or case series, that all sounds nice, but it doesn't really tell us what is best for our patients. Currently, 2016, there are 6 companies that are, as far as I know, in the United States that are doing spinal cord stimulator systems. You have Medtronic, St. Jude, Boston Scientific, Nevro. The first 3 are generally termed the big 3. Nevro is the new kid on the block as far as the last few years. StimWave's creeping in, and Nuvectra. I have no experience in Nuvectra, but they do have an improved system. A gross comparison, at least of 4 of the systems, as far as MRI conditionality. I'm sure I try to update this every year. Every year it changes. As far as MRI conditionality, there might even be some errors on this right now. But nonetheless, Medtronic, generally, you have full MRI conditionality for their percutaneous leads up to 1.5 Tesla. Basically, everyone is there now with percutaneous leads. As far as the paddle leads, not so much total body, but head and extremity, yes. Number of contacts, they're generally all 16 versus Boston has the 32 contact system. IPGs there are non-rechargeable, there are rechargeables. Current versus voltage, you'll hear a lot about that throughout the year. And then the biggest programming change really is with patterns or frequencies. So Medtronic has been, the first kid on the block, if you will. They've been here the longest. They've been doing tonic stimulation. Boston Scientific is evolving to different frequencies and their own algorithm for burst. St. Jude, as you already saw, has de Ritter's burst algorithm, and you saw the pulse widths, frequencies, et cetera. What's nice about that system is you can switch between burst and tonic. You're not just sequestered to one type of pattern. And then Nevro is the 10K, which is great, but that's what it will do. It's not going to do anything else. So maybe in the future you're going to have more versatility in the IPGs because not everyone, like I said before, likes tonic, and not everyone likes 10K, and not everyone likes burst. So you may have to do a little bit of playing around. And it's true you can sometimes trial through different systems with the same leads in place since they all have the same ISO standard. As far as DRG stimulation, this company, Spinal Modulation, was purchased by St. Jude just a couple years ago. Got FDA approval for its use in February of this year. So you might have heard about this in your institutions. There's no MRI conditionality right now. You can use up to 4 quattrodes, and it's FDA approved for T10 and below. You have a rechargeable system, tonic pattern. And we'll talk a little bit, Lawrence is going to talk a little bit about this in just a bit. So you might be asking yourself, well, who is doing spinal cord stimulation? How many of you are anesthesiologists in the room? How many of you are neurologists? How many of you are PM&R? How many of you are interventional radiology? Any internal medicine? Any psychiatry? Any EM? Neurosurgery? Orthopedic surgery? Okay, as you can tell, there are a lot of people doing this stuff, right? And what's kind of challenging is you go to an anesthesia meeting, or you go to NAS or PM&R meeting, or you go, you're going to hear your own slant on things. So just to understand that a lot of people are doing it. There are lots of different ways of doing it. It's really useful for you to try to go to different meetings over your lifetime to see how different groups are doing things. So this is from 2009 Medicare data, looking at who is doing this. As you can see over time, this is going from 2009, 2008, 2007, 2006, 2005. You can see the percentage of anesthesiologists doing this is shrinking. It's not because they're reducing. It's just that because more neurosurgeons, more orthopedic surgeons are getting into it.
Interventional pain management could be anybody, and who we just talked about. And PM&R, as you can see, is slowly growing, and hopefully it will continue to grow. So it's going to be a multi-interdisciplinary field who's doing this technology. It's not going to be beholden to one. And you're going to see pros and cons to having surgery-trained people versus anesthesia-trained people versus PM&R-trained people versus IR people. That's just how it is. To get the most, I think, bang for your buck as far as learning about these technologies as well as other types of therapies like targeted drug delivery, you have a couple societies you should really get involved with. The International Neuromodulation Society and the North American Neuromodulation Society. The annual meeting is coming up here in January 19th through the 22nd in Las Vegas. It's annually in Las Vegas. I think it'll continue to be so unless Lawrence has anything to say about 3 more years. Yeah, okay. It historically has been right before Christmas. That kind of irritated some people who had families, so we've done it now after Christmas. Hopefully you can all make it. They do put on a fellows workshop. I'm sure Lawrence is going to talk about this. We really are trying to engage fellows as much as possible early in this process. The International Association for the Study of Pain, who I think is the primary pain research society, every year they do a global year against. Last year it was neuropathic pain. This year it's pain in the joints. And 5 years ago, I would have said I would never use neurostimulation for pain in the joints. I mean, there are a lot of other things we could do. Totally changed now. With peripheral systems or dorsal root ganglion systems, there are a lot of awesome things we can do for pain in the joints. And we can talk a little bit about that as we do our cadaver workshop. The primary journal I would say in this area is Neuromodulation. Not to say you don't see articles in anesthesiology, ANA, anywhere else, but Neuromodulation tends to have really the most high impact as far as neurostimulation articles. And so I'm going to kind of fade into the last 15 minutes of our talk talking about decision making. So the last half hour or so has been about, what is this stuff? How does it really work, even though we don't truly know? But here I am as a pain fellow, or here I am thinking about getting into neurostimulation. How do I decide, what I should choose, how I should do this, and how do I balance all of those risks? So this is an excellent article out of HBR. It came out a few years ago. It was recommended to me by a colleague, and he gave a great framework for how to make decisions in your everyday life. It turns out you make thousands of decisions. You've already made probably 1,000 decisions this morning. When are you getting up? What are you going to wear? Do I brush my teeth? Where do I go? How do I get there? Everything you've done, which coffee you chose, you've made 1,000 decisions. And you don't even think about a lot of those decisions because they come so naturally. But there are going to be decisions that eventually will come naturally that may not become so natural, at least at first. So to keep it very simple, you do want to think about all these risks associated with neuromodulation and then the benefits associated with neurostimulation. It's very easy to get lulled into how great this stuff is because we're going to later on talk about how awesome this stuff is and give you some cases. But I did point out that 1/3 complication rate just to make sure you guys stay humble, stay true, and understand there are a lot of complications we do see, and we're working to reduce these complication rates over time. But then the question is, what do you do if you don't use neurostimulation? So what are we generally using in this country to help people with pain? You can a little bit louder because I can't hear very well. Narcotics, opioids, the cross. Anything else? What was that? Procedures, maybe other interventional procedures, steroid injections, etc. Yeah, and they come with their own risks as well. And it's kind of interesting, especially right now in 2016, I think you guys are all very familiar with the risks of opioids because of the media and because of the CDC and everyone else. Those risks have always been there, but they're just becoming a little bit more superficial as far as our awareness. But yeah, I think we've overlooked some of the major risks with opioids in this country over the last 5 years. I'm not saying there's not a role for opioids. I just think that we just haven't looked at every risk associated with them. And yeah, there are a lot of risks. So not only are there risks with acute use, but there are major adverse effects with chronic use. How many of you guys talk to your patients about hypogonadism, low testosterone levels, dysmenorrhea, amenorrhea? Are you all doing that? Great if you are, but you know what? Many pain physicians don't. Many patients don't realize that the opioids are causing all of those issues. So it is really important to ask those questions. Immunosuppression, Of course, withdrawals if they, forget their pills at home and they go on a trip. Especially now, it's so hard to get a refill or get another prescription if they're somewhere else because of all of our regulation. So they're going through withdrawals and finally saying, screw this, I'm done with this therapy. They develop tolerance. There are, of course, risks with abuse and addiction, which can range from 3 to 20% depending on which studies you look at. Opioid-induced hyperalgesia, I'm sure you're all familiar with that, yeah? So what is opioid-induced hyperalgesia? Total body pain. Yeah, so it's a decreased threshold to nociceptive input, right? So they're more sensitive to pain over time. And so hyperalgesia, in my opinion, is the reason I like to get patients off of opioids more than anything else, actually. Because if you're giving something to help them with their pain, but it's making their pain worse over time, then why are you giving it? The problem with hyperalgesia is that we've had animal studies in the last 15 years. Do we have hard, concrete evidence that hyperalgesia is happening in every individual that you're seeing that's on chronic opioids for, let's say, longer than 6 months? No, it may not be apparent, but you do use, and it's also difficult for clinicians to differentiate between tolerance and hyperalgesia, but nonetheless, if you have someone who originally came in with low back pain, for example, got on opioids for whatever reason, even though that's not evidence-based, and then they're starting to complain of neck pain, joint pain, hand pain, you start to wonder if they're going through hyperalgesia because now that threshold to pain has decreased and they're starting to sense pain in places they didn't have before. Another important topic is impairment while driving. Every state has their own rules and regulations as far as drugged driving. In the state of California, where we practice, if an officer sees any impairment at all, you're getting a DUI. Drugged driving is drunk driving. And then diversion, which is a huge public health issue. We know that the more opioids we give to an individual, the more opioids will be in that community and the more risk of opioid-related adverse effects in that community. All right, so there's the culprit right there. You've all seen this in the newspapers, the climbing death rate related to opioids, all-time high in 2014, nearly 28,000 deaths just associated with opioids alone. A majority of those were prescribed opioids. They were not your heroin. They were not your whatever other illicit opioids. They were prescribed. Now, whether they came directly from the physician or diverted through friends and family or then to the street and then purchased, doesn't really matter. Those were prescribed at some point. And so we really need to keep an eye on that public health aspect of things. And just looking at age-adjusted death rates due to drug poisonings, this is from 1999-2000. Don't worry about the parameters. Blue is low, red is high. 5 years later, you can see by county level. If you guys are from Illinois or from Southern California, you can look at the counties there, and then you can see in 2008, 2009, and then certainly in the last few years, that's gone even higher. All right, so let's say you've decided, all right, Dr. Naidu, I want to do neurostimulation for my patient. Well, which one? There's so many options. 3 years ago, all we were talking about was spinal cord stimulation. Our very first SSF meeting, we just talked about spinal cord stimulation, nothing else really. Now you've got a lot of options. Now you've got DRG, now you've got burst, now you have HF10. What should I do? So this is a very generic table for you to think about where and when you should think about certain technologies. And sometimes it's not very straightforward. Sometimes there are technologies where you may, in fact, consider both. Maybe trial one versus the other, or you do two systems, as we'll talk about in our case summaries. So spinal cord stimulation or dorsal column stimulation, as I mentioned, neuropathic conditions, ischemic conditions. Okay. Now, with that said, I've been doing this now for 5-6 years. The efficacy is okay. I would say probably 60 to 70% of my patients are going on to have an implant, but all we're looking for is a greater than 50% relief, and then some other metrics we'll look at. I've only been doing DRG stimulation for a few months, but either it works or it works like 90 to 100%. So the efficacy I've seen so far, maybe we're choosing the right patients, I don't know, it's still early, but you're seeing a far greater effect if you choose the right indication. And for DRG stimulation, patients with CRPS, persistent post-surgical pain syndromes like post-thoracotomy syndrome, post-inguinal hernia raphe syndrome, whatever post-TKA, that's where you want to think about DRG stimulation or a monogo oligoneuropathy. Burst stimulation, we're just starting to have our first few patients with burst, so I'm still getting a feel for it. But axial back pain, FBSS, probably other situations certainly can help in radicular pain. And then HF10, historically, we had difficulty in addressing axial back pain. Right now, it fits in my own personal algorithm for axial back pain or for FBSS. I'm sure as you're going to learn throughout today, Lawrence will have his own opinions on things. But this just gives you a starting point on where to think about which technologies go where and for which situations. So outcomes. This is probably the most important thing to take away from today's talk. We're not great at measuring outcomes in our clinical practice. We do it in our research studies. The biggest thing I've learned working at UCSF is that patients don't like filling this stuff out. One of the outcomes we look at is patient satisfaction. And the patient satisfaction has gone down with the more and more instruments we give patients. So right now we have these instruments available through our EHR on a voluntary basis. So that's not ideal as far as really tracking outcomes and being able to do research, but we also want to respect patients' autonomy and their wishes as far as whether or not they do these instruments. So here are some examples. For function, you have the Oswestry disability, I'm sure you're all familiar with. We use the HUDAS 2.0 because it's non-proprietary, and it's also a well-validated functional assessment scale. Quality of life, you can use the short form 12 or 36. The 36 is proprietary, so many will use the 12. Medication use, as far as opioids, as far as screening before opioid use, how high of a risk are they going to be for misuse or diversion? That's where the SOAP-R comes into play. For depression, the PHQ-9 or Bex. Anxiety, the HADS. Does anyone know what catastrophization is? Wechter, do you want to give a shout out as to what it is since you raised your hand and now you feel bad that you raised your hand?
That's where they over-exaggerate sometimes.
Awesome. So the catastrophizer is someone who says, you might see them as an anesthesiologist before surgery. Of course, they're in an anxious state, but they're like, okay, well, today I'm going to get my knee done, and of course, I'm going to have pain forever. It's going to get infected, and after it gets infected, I'm going to need an amputation. After I get amputation, I can't walk, and then I'm going to die. They're the person who can't rationalize a way to stop that flow towards total negativity. And this has been proven to be a major risk factor for the development of chronic pain after surgery. So for this reason, we've been using it. As you heard, I'm the director of acute pain services, so I'm very interested in catastrophization for perioperative use, but I'm also trying to get it used for chronic pain to see if individuals are high catastrophizers and may, for whatever insult, whether it's a flu vaccine or a trauma or a surgery, then develop chronic pain afterwards. It's kind of nice to know who's at high risk or who's not. And then the last battery are the pain assessment tools. There are so many out there, but the BPI is very nice. It's brief. It talks about pain interference. The McGill is phenomenal, but it's extremely lengthy. Patients may not like that. And then as you've been hearing, we talk about percent relief because insurance companies want to know about percent relief. It's such a small thing. It really means so little in the grand scheme, the grand picture of your patients. So really try to assess something from each of these categories as far as your patients. And that's going back to that biological, psychological, sociological model of health and of pain, where you really do get a sense of their functional abilities, their quality of life, etc. All right, to summarize in the last 5 minutes, and then we'll have some time for questions. Neurostimulation can be an effective method to manage pain. With the current epidemic of opioids, other therapies need to be considered. Goals of care to improve function, reduce analgesic medication use, and improve quality of life. The selection of candidates must be scrupulous. I can't say that enough. Really get to know your patients. It may take a few of them to get burned in order to realize this, but I really suggest knowing your patients well and also having a lot of team members involved. I'll stress it more in the case studies, but I work like this with our pain psychologists in determining who is and who is not a good candidate for this therapy. And it's not just about the therapy, it's just who's more amenable to reversibility in their pain. I think that's a bigger question to ask, and our pain psychologists are very good at helping us with that. It is costly. We're talking about tens of thousands of dollars, so we must demonstrate cost effectiveness or reduce the cost of implantation, so we'll bother the the vendors with that, just make these $100, guys, and then we'll be fine. And then the technology continues to improve. So when I was, in your shoes 6 years ago, I mean, it was just like, here are 2 leads, here's a battery, there you go. And here's a frequency. Now you guys have so many decisions, a lot of decisions. It's kind of exciting, but it's also daunting. So try to absorb as much as you can in this year. And then we must continue to improve our education and training surrounding the use of these devices. Remember safe. And then I think having this workshop, having the cadaver lab is going to be a memorable thing for you guys. I love coming back here. I think it's a lot of fun to just talk and figure out what other people are doing around the country. And hopefully we make it useful for you.